Senolytic drugs represent a fundamentally different approach to treating chronic conditions compared to traditional anti-inflammatory agents like NSAIDs, nonsteroidal anti-inflammatory drugs, and corticosteroids. While all three classes can reduce inflammation and associated symptoms like pain or swelling, only senolytics aim to remove the underlying source of inflammation at the cellular level. This distinction marks a shift from reactive symptom management toward proactive regeneration and disease modification, especially in aging-related diseases such as osteoarthritis, frailty, and neurodegeneration. The key difference lies in mechanism of action. NSAIDs such as ibuprofen and naproxen work by inhibiting cyclooxygenase (COX) enzymes, primarily COX-2, thereby reducing the synthesis of prostaglandins that cause pain and inflammation. Corticosteroids like prednisone, on the other hand, act more broadly by mimicking cortisol, suppressing the immune system, and blocking multiple inflammatory pathways, including cytokine production and leukocyte migration. Both types of drugs blunt the body's inflammatory response, but do not address the root cause that initiates the inflammation. Senolytics work differently. Instead of merely damping down inflammation, they target and eliminate senescent cells, which are damaged, non-dividing cells that accumulate with age and disease. These cells release a toxic mix of inflammatory factors known as the senescence-associated secretory phenotype, SASP. The SASP is not only inflammatory, it disrupts tissue structure, promotes fibrosis, impairs regeneration, and sensitizes nearby nerves. By clearing these cells, senolytic drugs remove the source of chronic inflammation rather than temporarily suppressing its effects. It's a deeper intervention aimed at changing the trajectory of degeneration itself. This difference has profound implications for long-term outcomes. NSAIDs and corticosteroids can be effective in reducing symptoms in the short term, but their continued use comes with significant drawbacks. Long-term NSAID use is associated with gastrointestinal ulcers, kidney dysfunction, and increased cardiovascular risk. Chronic corticosteroid use carries an even heavier toll, causing immunosuppression, osteoporosis, muscle wasting, blood sugar spikes, and even neuropsychiatric effects. These drugs treat the visible fire of inflammation but do nothing to prevent the fire from reigniting. Senolytics, by contrast, are being designed for intermittent use. Studies in animals and early-phase human trials suggest that even short-term senolytic treatment can yield lasting benefits by reducing the senescent cell burden. Because senescent cells accumulate slowly, periodic clearing may be enough to reset tissue health and inflammation levels. This offers the exciting possibility of episodic treatments with long-term effects, reducing the need for daily medications and minimizing side effects. In some studies, a single course of senolytics improved physical function and tissue health in aged mice for months afterward. The safety profile of senolytics is still under investigation. Some agents, like the combination of dasatinib and quercetin, have been tested in humans and shown to be generally well tolerated when given intermittently. However, certain senolytic compounds, especially those originally designed as cancer drugs, like navitoclax, can have off-target effects such as lowering platelet counts. The key challenge now is developing more selective senolytics that target senescent cells while sparing healthy ones. Natural compounds like physidin and ovanillin are particularly promising due to their senolytic activity and relatively mild safety profiles. Another important distinction is scope of benefit. Anti-inflammatory drugs tend to provide localized or temporary relief from symptoms like joint pain or swelling. In contrast, senolytics may confer systemic, multi-tissue benefits, not only reducing joint inflammation, but also improving vascular function, preserving cognitive health, enhancing bone strength, and potentially increasing lifespan and health span. Because senescent cells contribute to many age-related diseases, their removal could yield wide-ranging improvements across bodily systems. That said, senolytics are not a panacea. They are not yet approved for routine clinical use outside of trials, and much remains to be learned about optimal timing, patient selection, dosing schedules, and long-term risks. Inflammatory processes are also necessary for wound healing and immune defense, so eliminating all senescent cells indiscriminately could disrupt normal repair mechanisms. Precision will be critical. In conclusion, the core difference between senolytics and conventional anti-inflammatories is that one aims to erase the cause, while the other seeks to mask the symptoms. NSAIDs and corticosteroids may still have a role for acute inflammation and flare-ups, but for chronic, age-related degeneration driven by cellular dysfunction, Senolytics offer a more hopeful and transformative approach. They embody the next generation of therapeutics, designed not just to manage disease, but to restore and rejuvenate the systems that keep us healthy in the first place.